Okay, hopefully the slides will be a little bit brighter this time. So I'm going to talk about prediction and potentially management of preterm birth. This is the Australian perinatal mortality data here on the left-hand side. I've put the New Zealand data as well because in New Zealand they actually tease it out into 3 categories that includes terminations of pregnancies, stillbirths and neonatal deaths. And what I wanted to just show you was that preterm birth is responsible for about 16% of all deaths in Australia. If you took the top line out, which is congenital abnormality, it's by far and away the biggest culprit. If you look in the New Zealand data set and just look at neonatal deaths, 30% of them are related to preterm birth. And I find this slide quite interesting because I'd not really recognized the significance of iatrogenic preterm birth, which is the blue sides on the right-hand side. You can see that about 40% of preterm birth is actually medically based. And certainly in my practice, most of that at very early gestations is related to preeclampsia or IUGR. So I think the screening program that we've instituted for that has been very important. And you can then see spontaneous preterm birth in this lighter blue makes up again about 1/3 of cases. So I think we also have to define what we're interested in achieving. So for me, the major issue is preterm birth before 34 weeks, rather than completely up to the 37-week endpoint. And most of the data that I'll show you is related to that. And then I'm more interested in idiopathic spontaneous preterm birth in this talk than either PPROM or iatrogenic delivery. And the cohort I'm going to concentrate on are women who are apparently asymptomatic and low risk. So this was data that JIAMS published now 20 years ago. I can actually remember reading this on a train from London to Leeds. There you go. It made an impression on me. So it was interesting data because it showed in a normal population cervical length is about 35 millimeters and is normally distributed. And then if you had a short cervix, the shorter your cervix was in these black bars, the higher your risk was of preterm delivery. And the reason I remember where I read it is that I was sitting with Kypros on a train for 3 hours, and we came up with this concept of actually using these likelihood ratios to generate risks and of some preventative intervention. And that went on at King's to become a trial of cyclage and then a trial of progesterone. And this is the survival curves that JIAMS published. In America, just notice that they use a 25 millimeter cutoff. So you can see if your cervix is less than 25 millimeters, you have a much more significant rate of early delivery. Now, sorry, it's a bit dark on that screen, perhaps not too bad on this one. This is just an example, because I think this is how most obstetric cervixes are assessed at 20 weeks gestation. This is a transabdominal scan. You can see the bladder's full. That gives you a nice window to see the cervix. It's actually making the cervix falsely longer than it is. And the other thing as someone reporting imaging is, when you look at this measurement, you can't really tell what you're measuring, and you certainly can't tell whether the calipers are at some endpoint or not. But I'm showing you this because it shows the cervix is 52 millimeters long. We did a study where we compared transabdominal to transvaginal measurement. You can only measure the cervix properly, or you can only measure it transabdominally if you have a full bladder, but the full bladder tends to increase cervical length by an average of 20%. If you have an empty bladder, then you can't measure the cervix 1/3 of the time. This is the same patient. This is the transvaginal scan. The cervix is in fact 22 millimeters long, not 52 millimeters long. So I would suggest to you that every single cervical assessment that we do needs to be transvaginal. And this is the other data set that we had. If you looked at those women that had a short cervix, through transvaginal scanning and then looked at the performance of the TA technique, it had 10% sensitivity and only about 90% specificity. So I think the concept that you can do anything that is of value with a TA approach has disappeared and gone out the window. As with everything in ultrasound, I think that you need a standardized approach for measurement, and this is the approach that we use. Again, it's based on the approach from King's in the UK. You can see that down the bottom it includes things like making 3 measurements over a 3-minute period. The cervix is a dynamic structure, and it does change, and you will certainly see some patients where it changes quite markedly in that time. Although we note the presence of funneling, and in fact if you put some fundal pressure on, sometimes you can invoke funneling, what we do really is measure length rather than the size of the funnel. So this is just an example of a normal cervix here. You can see there's a little Nabothian follicle in the middle. This is obviously the transvaginal probe at the top here, and this is the vaginal wall, so you just have to be able to recognize where the vaginal wall and the cervix interact, or where the boundary is here. And then this is the internal cervical os at this end here. Might just play that one more time. And we measure it in a straight line. When you put the probe in initially, you then just need to relax the probe back so that you're not putting pressure on the anterior lip. Because when you put more pressure on, you actually extend the closed length. I think there's value in this transvaginal assessment at 20 weeks for a number of other reasons as well. This is placenta here. So in fact, the placenta lies over the internal cervical os. I think it's important first that we recognize that, obviously because of the risk of placenta previa. And we also, for these cases, then recognize the risk of vasa previa, and so use color to make sure there's no vasa previa. And if you're doing a transvaginal scan for a couple of minutes to get those measurements whilst the cervix might be acting in a dynamic manner, I think these are other things that you can do during that time. We now have a lot of data internationally about cervical length. So this is French data from Laurent Salamon and Yves Ville, and they prepared this normal range of cervical length on the basis of 4,000 patients. And essentially you can see around the 20-week mark when we do an anomaly scan, if we had a 25 millimeter cutoff, we'd expect only about 2% of our patients to end up in a high-risk group. So it's a very manageable risk cutoff in terms of defining a cohort where you might plan some intervention and further surveillance. This is data from Kipros's group. Iatrogenic published this paper that showed that as your cervix gets shorter, your risk of preterm delivery goes up. You can see the likelihood ratios really start to go up after you get down below about 15 millimeters. And then they produced a table of likelihood ratios for deliveries at different points in time. So in this paper, based on 50,000 women, they can give you a likelihood ratio for delivery before 28, 30, 32, 34 weeks, depending on what your cervical length is. So there is the potential, and I don't know many people that actually do this at the moment, but there is the potential to use this information in exactly the same way as we screen in the first trimester for, say, preeclampsia, because we now know a variety of different likelihood ratios for different risk factors. So, for example, you can see, where are we? Obstetric history, previous preterm birth before 32 weeks gives you a 4-fold increase level of risk. These are a whole host of risk factors that we have, and then you could add, I'll just go back a slide, the likelihood ratios that you had from cervical length on top of that. So this is just an example here of a slightly short cervix. You can see that you've got a degree of effacement at the internal cervical os, and I think that's another value of the scan. You know, as an obstetrician, if I see someone labour ward with preterm preterm labour and do a speculum examination, I can see the outside of the cervix and offer the external topography, if you like, of the cervix looks completely normal, despite the fact you've already got some effacement at the internal cervical os. This is just another example of that funnel that you can see that's coming down in the middle of the cervix. It's important that you make sure you recognize that and then measure the cervical length accordingly. Another example here where, again, you can see some funneling. This was actually induced by a bit of fundal pressure for this patient. And finally, this is actually the same patient as the last one, just demonstrates the dynamic change that you sometimes see as that funnel really develops and comes down. You know, this cervix is almost beginning to be open. So how should we manage this if we see a short cervix in a asymptomatic patient? Well, I think there's now a body of evidence that suggests that we have a useful treatment strategy, and that is to give women progesterone. So this is the UK trial that I was involved with in the background in recruiting patients, published by De Fonseca and Nicolaides in the New England Journal, 2007. And it showed, these are the survival curves, that if you gave women with a short cervix progesterone, they had about a 50% reduction in preterm delivery before 34 weeks. This was data from Roberto Romero's group in the United States, and again it showed a similar reduction in preterm birth here before 33 weeks, and also some reduction in some neonatal morbidity. They also did some work where they looked at this, you can see as a composite here, so cervical length, different measurements here with different relative levels of risk reduction. And Roberto Romero has published this meta-analysis. In fact, this is an updated version of it, which includes the negative data of the Optimum study done in Edinburgh. It's amazing that you, if you live in the UK and spend a lot of money on a trial within the UK, you can publish your randomized controlled trial in the Lancet, even if you changed the criteria for entry of the study after you started the study, but there we go. So negative trial here, and because the boundaries crossed one, you can see there. But overall, you still get the same result with all of these studies. So sometimes we might manage patients in a slightly different way. This is a lady that I've been doing some cervical surveillance on. She'd had a previous preterm delivery. We didn't really recognize the cause of that. We decided to use serial cervical surveillance rather than putting a stitch in. She was on progesterone from early pregnancy, and you can see here that we're beginning suddenly to get some funneling and shortening of the cervix. The cervix is about 12 millimeters long here. And so we actually then put a stitch in at this point. You can see the stitch here, and we have slight increase in cervical length up to about 15 millimeters. In our group, only about 4 of us put most of the stitches in. This is instant feedback on your surgical ability. So you can see, in fact, I'm not very happy about the fact that this stitch is so close to the cervical canal. I would have preferred that component to have been further down in the posterior lip. But it does actually help me as an individual. It's quite painful in terms of self-reflection, but it does, I think, help improve my performance gradually. Where are we at the moment? I would be a strong advocate of cervical screening for women who are asymptomatic at 18 to 20 weeks, because I think we have a useful treatment strategy. This is going back to the De Fonseca data, and just notice on the right-hand side, the group that had most benefit in this trial had a cervix 11 to 15 millimeters in length. And indeed, we actually give progesterone to everyone with a cervix less than 25 millimeters in length. The group that had least benefit were the women that had a short cervix. It may be that you're trying to shut the gate after the horse has bolted. And that just makes me wonder whether there are other things that we should be doing on the right-hand end to see if women are potentially at risk of preterm delivery and extending our use of progesterone to other groups. So if we just think about the process of change of the cervix during the course of pregnancy, the cervix is actually very difficult to look at in the first trimester because you can see that the body of the uterus really is continuous with the cervix, and the fibers and the collagen matrix that you have at that stage, the lower segment and the cervix are very similar in structure. And the cervix absorbs water, and that collagen matrix becomes, if you like, more porous, and there's less cross-linkage and less integrity, structural integrity to it during the course of pregnancy. And if you think about the process of change of the cervix through pregnancy, it tends to soften and then goes through a process of effacement and dilatation. Those would be perhaps the 3 stages. And softening may in fact precede shortening. So the question is, do we have a tool where we can assess softening as well as a tool where we can assess length? And this is where the elastography potentially comes in. So we've been doing some cervical elastography. We've been doing this on and off probably for about 5 years now. We started using a variety of different technologies that use strain. The problem using strain, in fact, is that you are obviously applying individual operator pressure to the cervix. That's where the strain comes from. And so that would be different with each examination that you do. So trying to establish a method that you could actually use that was calibrated across patients is very, very difficult. These are all of the publications that have been written on elastography. You can actually see Toshiba actually feature quite strongly in this list. And we've now moved on to use a technology that Toshiba have developed called Shearwave. And this is using the lateral propagation of the sound wave to basically give you a calibrated measure of tissue density. So this is the physics of that process. I think we might miss that. This is the obstetric way of thinking about this. If you imagine the normal ultrasound we use is the drop going down in the middle, and normally we're looking at ultrasound going back up to the transducer once we've fired it out of the transducer. Here we're more interested in the ripple effect, if you like, how that sound wave is then propagated laterally. So the information that I can find about how Shearwave works, Toshiba actually feature quite strongly in this on the internet. So this is obviously a Toshiba piece of information. And we've already heard about how if you have soft tissue, the sound wave essentially is just propagated straight down and back. Whereas if you have tissues of different densities, you're beginning to get lateral dissipation. So here we use the 2 different maps. We actually use this type of map to define areas that look soft here, where we've then drawn our 4 circles or regions of interest for measurement. And we use the propagation map as well. Most of the measures that we're doing are actually coming off this right-hand side, but we're placing the ROIs off the left-hand side. And we've been doing some work looking at expressing these data as ratios. And We're in very early stages of this. We would like to develop a normal range for the softness of the cervix with advancing gestation. We find that if you have a short cervix, that often tends to be associated with a softer cervix. We've also found that then, if we give women progesterone, it seems to become a little bit harder. We're also doing some work looking at operator variability, and it seems to be reasonably easy to get consistent measurements between operators. There's some situations where it's quite difficult to use this, but you might argue it's not of much added value. So one example here is you can see this is the whole cervix here. The whole canal is dilated. You've actually got a very small remaining closed portion of the cervix here. And this is just doing some elastography on here. You can see that when you get into the other tissues of the vagina and perineum, the waveform's quite chaotic. The other problem that we have in about 10% of patients that we examine is you can see the cervix here is quite curved, and this portion is quite vertical in relation to the probe. And again, this causes problems with the way the waveform is propagated. So there are some significant differences to using elastography in the situation of cervical assessment to tumor assessment. When you're looking at the liver, the tissue is typically pretty homogeneous, and here we're talking about a tissue that's fairly heterogeneous. And also there's these difficulties with the process of flow through tissue, and also the structure of the cervix. It's like having a piece of wood. The grain goes in one direction, and it's quite then direction dependent. So if you're looking along the grain or across the grain, you tend to get different results. So it's important that you try to control for these factors when you make measurements. So this is just an example, I think, where we are going to find it most useful, and that is in ongoing surveillance of patients who we have defined as having a short cervix. You can see on the left-hand side, perhaps the cervix is about 20 millimeters in length. And we're using the mapping here after we then start progesterone therapy to see if there's any obvious effect of that. And as I say, what we're hoping we'll find through this research is that we can demonstrate that progesterone is effective, is hardening the cervix, and that means we can perhaps reduce the level of surveillance that we have for some of these women. So finally, I think we've moved beyond a point where we can claim on the labour ward at 3 o'clock in the morning with someone who comes in contracting at 29 weeks gestation that preterm birth is purely an act of God. There are things that we can do, I think, to reduce the prevalence of preterm birth, and they should be part of our practice. Some of them are related to preeclampsia and IUGR, others are related to spontaneous preterm birth. In Western Australia, Jon Hyett started this statewide program called The Whole 9 Months. I think it's quite a useful website to look at, advocating a series of interventions to reduce preterm delivery. In our own practice, we've seen some interesting phenomena. We use progesterone as a primary tool for intervention, yet despite that, this is comparing women pre-cervical screening to post-cervical screening. We actually now put 3 times as many stitches in as we did 10 years ago. What's interesting about the stitches that we put in is that they tend to be for slightly different indications. So now, for example, we have a screening program for everybody who had a LETS previously, and you can see that as a result, we're putting more stitches in that category. We're actually putting less stitches in for women who had spontaneous preterm birth or PPROM in a previous pregnancy. And this is a very busy slide, but down the bottom here, it just looks at these are the pre-screening and post-screening groups. Pre-screening, about 16% of our stitches were rescue cerclages. Post-screening, 2.5% of our stitches are rescue cerclages. So I think that there is a significant shift in our clinical practice. We no longer believe that preterm birth is an act of God, so that means we audit our practice. And we've developed a scoring system for defining whether we actually went through an antenatal process of assessment appropriately. We have one for low risk and one for high risk women. And this just shows in low risk and high risk cohorts, we've scored women and our performance, and you can see about 5% of the time we felt we really performed quite poorly. I have to be careful what terms I use because everybody accuses me of trying to be the judge of their practice. About half the time we felt it had been adequate, but perhaps not completely best practice, and for us that was often a lack of any vaginal swabs, particularly in high-risk cases. And again, I think it's just given people a focus on their practice. So this is perhaps a slightly better placed stitch. So this is the advantage of being able to look at your cervix with ultrasound after you've done the intervention. This cervix before the stitch was inserted was about 9 millimeters in length, and you can see 33 millimeters long at this point in time. This is an example of what happens with a rescue stitch. So you put the stitch in, you actually have pushed those membranes back, so you can see you've got membrane separation there behind the stitch, and you tend to get ruptured membranes at some point. This is a cervix in the middle here. This is from earlier this week. I've never seen anything quite like this before. This is a woman with ruptured membranes. There's a pool of liquor sitting here within the cervix. And this is another woman with ruptured membranes. This is more commonly what you see. This is liquor in the cervical canal here. But it's useful to know when you're going to get a cord prolapse as well. So I think there's a number of reasons, again, why you can expand the surveillance to other populations. First trimester. I'm sorry that's a bit dark down on that screen again, but this is really just to demonstrate the fact that it's quite difficult to look at the boundaries of the lower segment in the first trimester. And also the cervix hasn't absorbed much water at this point. So in fact, mean cervical length is shorter in the first trimester than it is later in pregnancy. But it is difficult to split the cervix alone from the cervicoisthmic complex. And that makes first trimester screening quite difficult. But this is an example of a process of, again, using maternal characteristics and then markers, cervical length, here serum AFP, and putting them together. And in this model, a 60% prediction at a false positive rate of 10%, which I don't think is good enough for clinical practice. But it just shows you that I think at some point we will get into a situation where we have a potential screening tool at 12 weeks gestation. I think that's more or less all I've got to do. Yep, this is just another example of a second trimester cervix on one of these newer i800 machines. Thank you.